I'm Shailvi. I'm a surgery resident from California and a recent graduate from Hopkins getting my master's in public health. And we're stepping outside of Africa. We did a countrywide survey in Nepal, and so I'm going to present some of the data that we did there today. So first of all, when you talk about breast masses in general, normally in the Western world, breast masses themselves require, first of all, access to healthcare, basic access to healthcare. Second of all, you have to have multidisciplinary care, often involving radiation oncologists, surgeons, primary care physicians, and the whole spectrum of doctors. The etiology of breast masses is vast, and we know that. It comes from fibroadenomas to adenocarcinomas, both malignant and benign. But with that being said, a misdiagnosis of breast cancer shouldn't occur anywhere in the world, in the Western world or in developing countries either. So first of all, breast cancer is one of the most commonly diagnosed cancers in the world. It's about 10% of all malignancies that are detected globally. Furthermore, 45% of these, more than 1 million incident cases, and 55% of the breast cancer-related deaths occur in low and middle-income countries. When you look at the available data, the case fatality rates of breast cancer in developing countries is higher than that of high-income countries. We don't know the reasons for this. It could be pathologies different. There was a recent study out of Nigeria actually with colorectal cancer showing that the pathology is different for cancer in these countries versus Western world, but we don't know this much further than that. It also could be that there's no access to preventative care, and that when people come to get care for cancer, it's in a later stage than it is in other countries. So what did we do? The Surgeons Overseas, it's an NGO from New York City. They created this survey, Surgeons Overseas Assessment of Surgical Need, because first of all, the prevalence of surgical conditions in general, and furthermore cancer, breast cancer, is not known. And what I mean by prevalence is population-based data, what I mentioned this morning. We know a little bit about hospital-based data, fine, but those people who are unable to access care at a population level, what is their need? So the Surgeons Overseas assessment, it asks about a general spectrum of surgical conditions, including masses, burns, breast cancer, hernias, injuries, etc. So this portion is just on the breast masses part. And just to give you a basic idea of what the survey is, the first portion goes through demographic data of a household. What's the access to care that they have? How do they get there? How much does it cost? Are they able to access care? The second part just randomly chooses 2 members of the household and goes through a head-to-toe verbal examination. So all the data is self-reported, which is a limitation of the study, but that's what we did. In the Nepal study, which we did get ethical approval to do, we added a physical exam. And for the breast part, that doesn't help us too much because we weren't able to do that, but it validated the SOSAS tool, which was a big step in order because that was a previous criticism of the survey before. So just to let you know where the survey has been done previously, it's been done in Sierra Leone and Rwanda. And so the numbers are of unmet surgical need, and more or less this is what I mean. Unmet surgical need means there's a self-perception of I have a mass, I feel like I needed care, but I was unable to access care. And so then we were able to see what those barriers to care was. So that's what I mean by that. And when we look at breast masses specifically, in Rwanda it was 4.4% and 3.3% in Sierra Leone. So I'm here to tell you what we did in Nepal. So we performed this survey in Nepal just a few months back, and this is everywhere we surveyed in Nepal. We did a 2-stage sampling that was performed, and we picked 15 of the 75 districts proportional to population, meaning those that had more density of population were more likely to be selected. Within each of those districts, we did, after stratification for rural and urban, we did it with the DHS methodology. We picked 45 of those clusters and then sampled 30 households within each cluster. So a brief thing of our results, we sampled about 2,700 individuals and 1,350 households with a response rate of 97%. In Nepal, our unmet surgical need was 10%. For the breast mass analysis, we analyzed about 955 women. Of those 955 women, 15 women over the age of 18 reported a breast mass. That's about 1.6%. The age was young. It was about 40 years old, the mean age. 53% of those, 54% were literate, while some had no education, and the primary occupation was a homemaker. And just to give a general idea, 8 people said that they had the mass for over a year. The others were more recent, so it varies on how long the mass had been present for. When we look further about access to healthcare, we divided it with people who went to seek care and people who did not go to seek care, and we saw the reasons for it. The main reason that people didn't seek care was they were scared to. They didn't want to go to a doctor. The people who did seek care, 3 did get surgical care, and that could mean minor surgeries, biopsies, etc. And then 5 didn't, and the reason was, 1, they didn't felt there was a need to go, so why would they? And then the other was fear and no trust, and then inadequate monetary funds. So then when we look at this just in general, the main reason for not seeking care was fear and trust in the health system. If we extrapolate our findings to the current population of Nepal, it's about 70,000 women in Nepal may have undiagnosed breast masses. It doesn't mean they need surgical care. It just means that at some point they may need a surgical consultation. This was just to draw attention that the need of surgical care, at least for breast masses, is high and unrecognized. And so the true prevalence, like I said, it likely exceeds our estimates because this is all self-reported data. So we literally knocked on people's homes to ask to answer our questionnaire. There's probably stuff they didn't tell us, which makes sense. And so the true prevalence likely exceeds our estimations. With that being said, there is evidence now that in developing countries with urbanization, westernizing lifestyle, etc., that the incidence of breast cancer is going up in these countries. In addition to that, when you go to countries like Nepal, people don't present until late stages of diagnosis. So if you put those 2 things in combination, you likely have a lot of years lost due to breast cancer in Nepal. And just to give you an idea, the knowledge of breast cancer in these countries, so Nepali women do have, there was one study that was done that Nepali women do have misconceptions with regards to breast masses. More than 50% were unaware that breast cancer could be painless, that you didn't have to have pain in order to have cancer. And then furthermore, a 1/3 thought that you could be immune to breast cancer, that you could have a cure by a traditional healer. This result from a previous study in Nepal actually mirrors the results that we found in Rwanda and Sierra Leone, where they showed that people who didn't have a disability from a mass had a self-perception that we don't need care. And so then that's another reason they present much later. Furthermore, about 37% only went to traditional healers to take care of breast masses. So in conclusion, what we hope to do with this study and this kind of portion of breast masses is just to call for efforts to have preventative care. In Nepal, you don't necessarily have screening mammographies. You don't have things like this where women can go safely to get all this stuff done. So our idea was to maybe present this data in hopes that at current women health can integrate maybe mammography and some of this stuff for breast cancer. And in general, we think, and I think everybody would agree, that early detection of breast masses should be a primary goal worldwide and not just in developed countries. And that's it.